All right, good morning. Welcome everybody to Pediatric Grand Rounds. Today I have the pleasure of turning things over to Dr. Kapoor, who's going to introduce our speaker and our lectureship for today. Thanks, everybody.
It's a pleasure to be able to introduce again this year the Ron Lemire lecture. Ron was an iconic figure here at Seattle Children's. Many of you may have known him. You can see he spent and devoted his whole career basically to this institution and made a lasting impression on this institution and on those of us who were fortunate enough to know him personally. Ron had many passions, some of which had to do with his academic career, which were listed on the prior slide, but he also was a fan of the 4Fs. Let's see if I can remember them all. One you can guess here is fishing, family, friends, and now I forgot the fourth one. It'll come to me. Oh, fly fishing. That's 5 maybe. Yeah, and Ron, was a passionate fisherman. Oh, flying too, and because he was a pilot. But he was a passionate fisherman, and one of his best buddies in the fishing world and academically was Bruce Beckwith. They authored many papers together. They were great friends. Ron wrote this tribute to Bruce that was published, and as it's titled, Fisherman and Friend. And it really was a close and special relationship, both professionally and privately. This photograph of Bruce out on one of the local rivers fishing with somebody smoking a cigarette was taken by Ron. And Bruce was also an iconic figure, not just at Children's, but in the world of pediatrics. And of course, all of us know Beckwith-Wiedemann syndrome, but one of Bruce's most influential contributions among many, many as the head of pediatric pathology here at Seattle Children's was his exploration of Wilms tumor and his contributions to our understanding about Wilms tumor. And so I know both Ron and Bruce would be very, very excited about the talk we're going to hear today from Bruce Powell. And I didn't know whether which iteration of Bruce I was going to get today, the bearded one and the non-bearded one, so I put both photos there, and you'll see in a moment which one he chose to go with. I think it's the same individual on those pictures. Okay. So anyway, it's a pleasure to welcome Bruce. Bruce is clinical professor of pathology at Keck School of Medicine at the University of Southern California, and he's a pediatric pathologist at Children's Los Angeles, where he directs the Division of Anatomic Pathology. His main research interest is in diagnosis of childhood solid tumors, such as neuroblastoma, rhabdomyosarcoma, malignant rhabdoid tumor, and of course Wilms tumor. And he's been real influential nationally and internationally in the field of pediatric oncologic pathology. And he's devoted a considerable amount of his time to really educating others, both nationally and internationally. And he's participated in many courses internationally to try to help other professionals in the pediatric pathology world understand some of these complex tumors and how we diagnose them, especially with the revolution that's occurred in molecular diagnostics. So it's a pleasure to welcome Bruce, a good friend and a wonderful speaker. So I hope you enjoy this.
Thank you so much, Raj, for that really kind introduction. It's a pleasure to be here. I want to thank Suzanne. I want to thank Emily for having me here. So I'm going to begin. I have no disclosures to make, by the way. So I'm going to cover a little bit of the same ground that Raj did. When I was asked to do this lecture, I looked up Ron Lemire, and I found this article that Bruce Beckwith had written in the Birth Defects Research Journal, and very, very long article. It's got lots of details about both of them and their love for fishing, their friendship, and the thing that's really stood out to me was some of the quotes, and this one quote from Bruce Beckwith is, "My association with Ron began with a shared enthusiasm for the embryology and morphology of malformations, but soon evolved into the closest and most influential relationship outside of the family that I would ever experience." And that's written by Bruce Beckwith, this giant who touched so many lives and had such a marvelous and storied career. Now, actually, a year before that, Ron Lemire wrote this article about Bruce Beckwith, and Raj showed this same thing. And we are close to being brothers. So it's amazing the relationship they had. And one thing I pulled out of that was this extraordinary statement that Ron said, I made a list of 487 different events we shared together for over 40 years. And I kind of challenge anybody to come up with that many events, or even people in their own family. So it was an incredible relationship they had. The other thing I should mention is, of course, Bruce Beckwith has this very strong relationship to this institution. He was the director of pediatric pathology and laboratories for over 20 years here. But he also had a connection with my institution, Children's Hospital of Los Angeles, that Beckwith, way back in 1959, did 1 year of residency training in pediatric pathology at CHLA, and he also rotated through the ME office in Los Angeles. And during that time, while he was a resident in pathology, he was already beginning to make some pretty extraordinary contributions to the medical field. He was the first to describe incipient or in situ neuroblastoma. As we all know, he first described the cases of what became known as Beckwith-Wiedemann, and those were two tumors that we have in our files. One from the ME office, one actually from CHLA, and I think the first one was a case he went back to, I think from the 1920s or 1930s to make that connection. Beyond renal pathology, he had interests in sudden infant death syndrome. He did some initial work on describing the pathology of SIDS. But I wanted to talk about Wilms tumors because, of course, his major impact was his role in the National Wilms Tumor Study Group, which was fondly known at the time as NITWITS. And NITWITS is now part of the COG study, and this was a collaborative study where they were able to collect and examine almost all pediatric kidney tumors in North America. And getting that large volume of cases of what was otherwise a rare tumor, Beckwith was able to make quite a few very seminal contributions to our understanding of Wilms tumors, amongst which recognizing that not every pediatric kidney tumor was a Wilms tumor. Some were quite different. He was the first to describe the significance of anaplasia in Wilms tumor and recognition and significance of nephrogenic rests, which are small foci of immature nephrogenic tissue within these kidneys. So Ron Lemire, Bruce Beckwith, both giants in embryology, both very interested in developmental dysregulation of pediatric malignancies. So some basic facts about Wilms tumor. It's by far the most common renal tumor that's encountered in childhood. The majority, about 90%, are sporadic, so there's no known underlying predisposition, no family predisposition, but 10% are syndromic. And the importance of that is that it was these syndromic cases that first began to lead to the understanding of the genetic underpinnings of Wilms tumor. And even a smaller percentage are actually known to be familial. This tumor affects 1 in 10,000 kids worldwide, and it's a tumor of mainly young childhood. Prior to 1960, this 70% of children with Wilms tumors died of their disease. And it wasn't 100% because some children survived after surgery. But most children, even after surgery, would go on to develop metastatic disease, which could not be treated. Currently, using international protocols, the survival rate is approximately 90%. So in many ways, the story of Wilms tumor is a story of medical success. We went from 70% dying to 90% surviving in the span of less than 50 years. But although it's a success story in general, it's not a success story for everybody. And I want to illustrate that by talking about 2 children, both of which were treated at CHLA, AJ and TR. And we'll start with AJ. So AJ, the clinical story with AJ, she was a 14-month-old female, no healthy baby, no significant clinical history, brought to the emergency department with abdominal distension or mass on her left side after 2 months of non-bilious vomiting. On imaging, disclosed a large left renal mass, and a left nephrectomy was performed. This is what it looked like, and to the pathologists in the audience, the first thing one would think of would be, of course, Wilms tumor, this large, fleshy mass that's occupying most of the kidney and just displacing a little bit of normal kidney to the upper right-hand corner. And certainly the image, the microscopic image on the right side of this panel is very consistent with Wilms tumor. This would be what we call the triphasic Wilms tumor, where you have immature epithelial elements, those little kind of round structures. You have this kind of spindle cell stroma, and you have these more undifferentiated cells, which are blastemal cells. So if a pathologist sees this picture in this clinical setting, there's really no question what the diagnosis is. It's a Wilms tumor. You don't really need to do any more ancillary studies to establish that fact. So the examination disclosed this was a large Wilms tumor. There was no anaplasia, which means that there was no significant enlargement of nuclei, unusual mitotic activities, hyperchromasia, which is something pathologists look for. There was no nephrogenic rest in this tumor. This child seemed to have no evidence of invasion or extension outside of the kidney. And lymph nodes, which should always be taken with nephrectomies, all were negative for metastatic disease. So this fell into a local being based on pathological examination, stage 1, favorable histology, Wilms tumor. As we do nowadays, we, as much as we can, we try to submit this tissue for molecular genetic analysis. And interestingly, the next generation sequencing disclosed a WT1 gene mutation at exon number 7, which was a frame shift mutation, which is seen in a percentage of Wilms tumors. Germline testing was negative, so this seems to be a somatic mutation. And chromosomal microarray disclosed loss of heterozygosity in the P15.5 region, which was a large deletion. Basically, most of the short arm of chromosome 11 was lost within this tumor. So this was a child who had really typical Wilms tumor, no significant unfavorable features. She was treated according to the COG protocol for those types of tumors, which was nephrectomy followed by adjuvant chemotherapy, and her CT scans both before the surgery and after the surgery were negative for metastatic disease, followed by every 4 months further imaging to make sure everything was okay. And now we are 4 years down the road. This child is doing just fine. So that is a good outcome. That's the outcome we hope for. That's what we expect. Now you contrast that with TR. TR was a 3-year-old male. His history was remarkable of autism, but otherwise he was a healthy child. And he presented to medical attention because his dad saw that his urine had a pinkish tinge. Went to the pediatrician. Physical examination disclosed a mass in the right flank. Ultrasound confirmed that there was a large mass there, and a nephrectomy was performed. And you can see on the gross image, it's very similar to what we saw in AJ, a large fleshy tumor displacing normal kidney. But the histology is a little bit different. A little bit different in the sense that I mentioned anaplasia before, and this is what anaplasia is. I'm not sure if I have my, a pointer here, but you can see some of these nuclei are very, very large. They're more than 3 times the size of their neighbors. They're hyperchromatic, some of them. And in other fields, there are atypical mitotic activity. So this was a definition of anaplasia. It was not localized, but it was found diffusely throughout the tumor as an unfavorable histological finding. And this is a summary of this case, triphasic Wilms with diffuse anaplasia, which by definition means the histology is unfavorable. In addition, gross examination and microscopic examination disclosed extensive invasion of the renal sinus. The only thing good was that the margins appeared to be negative, but one of the regional lymph nodes was positive. So TR fell into a higher stage, a local stage 3, and the molecular genetics also had one unfavorable finding, which was 16q deletion. So how did this patient do? Well, TR at diagnosis on imaging already had bilateral lung metastases, so truly had a stage 4 disease, was treated on stage 4 disease protocol, underwent further surgery to remove the lung metastases, underwent whole lung irradiation down the road, flank irradiation down the road, boost of chemotherapy to this UH3, which is a quite toxic chemotherapy meant for the highest risk Wilms tumor patients, but continued to have relapses and continued metastases. And despite salvage chemotherapy, had further problems, and this patient unfortunately expired 2 years after the initial diagnosis. So for this patient, certainly the Wilms tumor is not a success story. So let's go back and kind of take a look at, how did we know about Wilms tumor? What's the early history of Wilms tumor? And really, Wilms tumor was described well before Wilms came around. In fact, the first person who actually looked at and described Wilms tumor was John Hunter. John Hunter was a British medical scientist. Back then, there weren't pathologists. There weren't, so everybody did different things. He was an interesting character. He was an irascible, skeptical person. He questioned the medical dogma of the day, and he was really I would think, the founder of medical experimentation. He wanted to prove things instead of just taking things on face value. And amongst other things he did was he was one of the first people to actually describe inflammation as a cellular process. So amongst all the different things he did, he collected a lot of medical specimens. And many of these specimens are now housed in a museum in the Royal College of Surgeons in England, which was a bilateral kidney tumor specimen that Hunter had collected. And interestingly, we go back to Bruce Beckwith. Beckwith actually went to this museum, and we're talking about 200 years later, and managed to get that specimen, managed to submit it for histopathological analysis and prove that these tumors are actually bilateral Wilms tumors. It's kind of amazing. But the first, I think, detailed clinical description of Wilms tumor came from a physician in London named John Rance. This was in 1814, and to put things into perspective, 1814, a lot of things were going on in that year, some bad things. Napoleon was contemplating how he'd get out of Elba and go back to Europe. The British had invaded D.C. and sacked the White House and the Capitol. On the good side, Beethoven during that year was finishing his composing of the Symphony No. 8. And in the medical field, a surgeon named Abraham Colles was the first to describe a fracture of the distal radius, which turned out to be the Colles fracture under his name. But Rance had a patient that he didn't know what to do with. And he wrote about his experience with this patient in one of the journals of these days. He's called a case of fungus hematoides of the kidneys. And it's actually a very sad thing to read through because it shows what this tumor does without effective therapy. The clinical course was that the tumor was discovered in mid-January of 1813, and they treated it with the biological therapy of the time, which was leeches, the chemotherapy of the time, which was herbs, purgatives, tonics, bicarbonate of soda. Nothing helped. The tumor got bigger and bigger, and you can see this didn't happen over a short period of time. This happened over a fairly long period of time. This patient was initially asymptomatic other than having a mass, but by November, she began to really suffer. Violent fits of pain, hematuria, got to the point almost a year after the initial diagnosis where she stopped eating, and according to Dr. Rance, on February 25th, 1814, finally closed the scene of her sufferings. So he wrote about this, and he wanted to know more about the tumor, so he basically did his own autopsy on this patient and kind of described the gross findings that we are familiar with today. After that, numerous descriptions of Wilms tumors appeared in the literature. You can see a lot of these names are fairly, some of these are very big. Cohnheim, the famous early pathologist, the Weigart, Marchand, all described Wilms tumor. And the interesting thing about this is that many of these early describers thought these were sarcomas because Wilms tumor has a propensity to form heterologous elements such as muscle, for instance, and cartilage. So they kind of looked at these as mixed tumors. They called them myoma, muscle tumors, sarcomatoides, sarcoma. And all these descriptions were being put into the literature. And then Wilms showed up in 1899. Wilms looked at all the old literature. He took 7 new cases of his own, and he looked very carefully at the histology. And he described them as Mischgewuchste der Niere, or mixed tumors of the kidneys. Mixed as what I said before, multiple different elements. And astutely, he theorized that these cells, which were previously thought to be true sarcoma cells, were actually embryological epithelial cells destined to form kidney. So he was correct there. He wasn't entirely correct when he was trying to figure out what germ layer they actually arose from. He thought they came from the mesoblastic blastema, the mesoblastic somites, and the mesenchyme. This turned out not to be entirely true, but he made a huge contribution to the field. And within a year, this was 1899, by 1900, people were referring to this as Wilms tumor. And I think maybe because Mischgewuchste der Niere was too difficult to say, so Wilms tumor was a lot easier. He also had a lot of other accomplishments. He didn't just do Wilms tumors, but he contributed other things to the medical field. So how does Wilms tumor, what's the epidemiology of Wilms tumor across the world? Well, obviously it occurs everywhere. This is a map of the world showing you the mortality rate for kidney cancers. And when you're talking about kidney cancers in children, 90% of them are going to be Wilms tumors. So this is really a map of the mortality for kidney cancers. And you can see that the lighter colored areas, the areas that are high income countries, the mortality rate is quite low. When you look at low income countries, the mortality rate is quite high. Every year, 14,000 patients approximately are diagnosed, and 5,000 of these patients will die of the disease. And if you do the math, that shouldn't be. If you have a tumor that's 90% curable, you can see a lot of children are dying unnecessarily just because they don't have access to up-to-date treatment. They don't have early diagnosis. Some of them don't get any treatment at all. So that's one of the problems that we have to deal with. If you look across the world, there are also variations in incidence of Wilms tumors that have genetic underpinnings. And what's interesting here is that the incidence of Wilms tumor is significantly less in East Asia, South Asia, and Southeast Asia, as opposed to in North America. As you can see, quite a bit less. And by the way, these bars, the blue is Wilms tumor, and those little bit of color at the ends of these things refer to the other non-Wilms tumors. And you can see that the numbers of tumors in the kidney that are not Wilms tumors in childhood are fairly insignificant compared to the numbers of Wilms tumors. Age, I mentioned before, it's a tumor of young childhood. Peaks kind of around age 3, age 4. It's one of the few pediatric tumors that's actually a little bit more common in females than in males. That's not true when the kids are less than a year of age, but once they're over a year of age, there's a pretty clear female predominance. And the incidence kind of drops off as children get older. So by the time you're like 10 or 11, it's very unusual. They're actually rare case reports that you can have Wilms tumors in adulthood. And that's a similar story to what we see in tumors like hepatoblastoma, neuroblastoma, where there's always a few cases, but extremely rare for that to happen. How do we diagnose this tumor? Well, clinical presentation, most patients at presentation are asymptomatic except for having abdominal or flank distension, or somebody perceives that there's a mass there that shouldn't be there. It's usually non-tender unless there's been hemorrhage within that mass. And unlike kids with splenomegaly, this mass tends not to move with respiration. That's true of most patients, but about 20% of patients will have distinct symptoms, which could be pain, could be blood in the urine, fever, hypertension, UTI, constipation, or weight loss. They may actually present with symptoms related to metastatic disease, but in the settings of Wilms tumor, that's kind of rare. Also rare is severe pain and rapid abdominal distension, which is what happened to the patient who had this nephrectomy. You can see acute hemorrhage underlying the renal capsule due to rupture of a Wilms tumor. On imaging, I'm not a radiologist, so the radiologists in the audience will know a lot more about this than I do. But as an overview, you can see that the standard with Wilms tumor in the USA is usually CT scan or MRI taken preoperatively to image both the chest and the abdomen, where the CT scan is best for disclosing pulmonary detail. It's rapid. The downside, of course, is that you have a radiation exposure, whereas MRI provides excellent organ detail but requires sedation. There's no real routine lab testing involved in Wilms tumor other than testing to confirm that the patient will be healthy enough to undergo chemotherapy. So the next step in treatment depends on where you live. So if you live in North America, clinicians will follow the COG protocols, the Children's Oncology Group. Pretty much everywhere else in Europe and other countries follow the COP, the International Society of Pediatric Oncology criteria. The main difference is that in North America, under the COG protocols, patients will generally be treated with upfront nephrectomy. So the diagnosis is made on clinical grounds and on imaging. The patient undergoes nephrectomy, whereas in Europe, these patients will undergo a neoadjuvant chemotherapy. They'll have chemotherapy first and then nephrectomy second. Which one is better? Both of them have a similar overall survival. From the standpoint of a pathologist, I kind of like it that we are in North America because we can see these kidneys before they've been altered by chemotherapy. And the other thing about the COG approach is that there's a small number of patients who can be treated if they have ultra-favorable disease. They may be able to undergo surgery alone, which of course doesn't happen under the COP protocols. Most of these patients that do not have high-risk disease will be treated with two-drug chemotherapy. So what do you need as a clinician from the pathologist if you're taking care of these patients? And the pathologist basically provides information, of course, of the diagnosis. Is it a Wilms tumor? Is it not a Wilms tumor? But also help with the classification of the tumor or the grading of the tumor and help with staging of the tumor. So diagnostically, this is, a pathologist sees this 3-year-old patient. The first thing one would think of would be Wilms tumor, like the images I showed you before. They tend to be these fleshy masses that once the kidney is bivalved, almost seem to erupt from the kidney surface. Histologically, I think I showed this image before. This is a classic triphasic histology of stroma, tubules, and blastema. But you may have other patterns, and other patterns could be tumors that are almost completely or completely composed of epithelium, such as in this field here, we can see all these primitive tubules. So that would be an epithelially predominant Wilms tumor. When you see something like that, differential diagnoses come to mind, such as metanephric adenoma, carcinoma, for instance, and ancillary studies often need to be applied. Another pattern one they see is a pattern which is composed almost entirely of blastema, these sheets of primitive brown cells. When you see this, obviously you have to think of other small round blue cell tumors, such as a Ewing sarcoma, such as a very poorly differentiated rhabdomyosarcoma, sarcoma, or even lymphoma. These all enter into differential when you see a blastemal predominant tumor. And then ancillary studies, this is immunohistochemistry of WT1, which is fairly sensitive, not entirely sensitive, but fairly sensitive for Wilms tumor. And then finally, another pattern would be a tumor that's composed mainly or almost entirely of stroma, this kind of spindle cell population of cells. Not uncommon at all in Wilms tumor, and we go back to those early descriptions of Wilms tumor where people describe skeletal muscle, and you can indeed have these heterologous elements within a Wilms tumor. To make things even further complicated, it's not uncommon to see totally heterologous elements within a Wilms tumor. You can see in these fields, you can see cartilage, you can see bone formation, you can see other elements within a Wilms tumor as well. These, when they're well formed, sometimes people refer to these as teratoid, when they're actually looking like they're forming organs as well. So that's what the pathologist needs to do as far as establishing the diagnosis, is to look at those different patterns. One thing I tell our residents and our fellows is that every single Wilms tumor I've looked at looks different from the last one. I mean, they all look different. Even the ones that you think are going to be easy, usually there's something that you have to work on, something that puzzles you. They're really fascinating in that respect. Other tumors you have to worry about, though. They're rare, but they occur in the kidney in children: congenital mesoblastic nephroma, clear cell sarcoma, rhabdoid tumor, renal cell carcinoma, and then a miscellaneous group of very, very rare tumors that can occur as well. Mesoblastic nephroma, this is actually the most common tumor in infants, most common renal tumor in infants. So if you have an infant that's 3 months of age, top of your list is going to be mesoblastic nephroma and then Wilms tumor. There are two forms, actually three forms of mesoblastic nephroma. The classic form, which you can see on the left-hand side, which basically is a spindle cell stroma-like lesion which kind of invades and surrounds native normal glands of the kidney, tubules of the kidneys. This is 25% of mesoblastic nephromas, and it's consistently associated with internal tandem duplications of the EGFR gene. The type that we see more commonly is the cellular mesoblastic nephroma. This is essentially the renal form of a infantile fibrosarcoma associated with this classic ETV6 and TRAC3 fusion. And then occasionally, rarely, you can have mixtures of the two types in a mesoblastic nephroma. Clear cell sarcoma, another thing one has to worry about in young children. This tumor has a history of being very aggressive. It was originally called bone metastasizing renal tumor of childhood, and a tumor that's associated with internal tandem duplications of B-core. Rhabdoid tumor, another contribution, I think, of Bruce Beckwith. When he pulled out all those tumors in his huge series of tumors over many, many years, he found that there were a number of tumors that just had a much poorer prognosis than the other tumors. And when he looked at them, he also saw that the histology was also quite different. These were called rhabdoid tumors because the histology looked like skeletal muscle, but they looked a little bit different from what we call a rhabdomyosarcoma. Cells had this copious red cytoplasm. Nuclei were big, vesicular, with big nucleoli. And a very, very grave prognosis from our children. This was very aggressive disease. And further study of these tumors disclosed that the vast majority of rhabdoid tumors are associated with biallelic inactivation of INI1 gene, also known as SMARCB1 gene. So diagnosis, of course, you have to establish that this is a Wilms tumor. Beyond diagnosis, the pathologist has to establish whether this tumor is going to be a favorable histology or unfavorable histology, because it has ramifications as far as how these patients will be treated, how they will behave, what the prognosis is. And the main thing that one looks for in a Wilms tumor is a presence of anaplasia, and if it's present, is it localized or is it throughout the tumor? As I mentioned before, it's defined by multipolar mitotic figures, nuclear hyperchromasia, and great nuclear enlargement as compared to cells nearby. and when it's diffuse, it has an adverse prognostic significance. Staging. This is a distillation. I mean, it's maybe a somewhat oversimplification, but this is how the COG stages Wilms tumors, where stage 1 is basically a tumor that's limited to the kidney and completely taken out. Stage 2, it's also completely taken out, but on examination, we find that the tumor has invaded outside of the capsule of the kidney or outside the sinus. Stage 3 would be a residual non-hematogenous tumor within the abdomen and or prior biopsy. Under the COG system, these tumors should not be biopsied prior to nephrectomy. If they are biopsied, by definition, you're upstaging a patient from stage, whatever low stage it could have been, to a stage 3. And finally, stage 4, like in other tumors, would be distant metastatic disease, and stage 5 would be bilateral involvement. As a pathologist, we mainly help by determining whether it's a stage 2 or stage 3 locally by carefully mapping out the specimen and seeing if there's invasion, also looking at the lymph nodes that are resected with the specimen, and seeing if the tumor has grown into the renal sinus or outside the capsule. This is these photomicrographs are showing what penetration of the capsule looks like. You can see on the left-hand side, the capsule is kind of starting at the left edge of this screen, and you can see tumor cells that are on the other side. Invasion of the capsule upstage to stage 2. Invasion of the renal sinus, often you'll see tumors extending into the perirenal fat in the sinus or undermining the major renal vessels in the sinus. So, okay, those are the major, what the surgical pathologist has to convey to the treating clinicians. But going back to Wilms tumor and how does it occur? How does the embryology, how does the formation of the kidney inform us of the mechanisms of Wilms tumor development? Whereas Wilms tumor is an embryonal malignancy thought to arise through abortive or disruption of development of the kidney, a disruption that can really happen at any point during the morphogenesis of the kidney. So we look at how does the kidney normally develop? And the kidney normally develops from 3 systems within the developing embryo and fetus. These systems develop from intermediate mesoderm, which is outlined here in that light blue, and you can see where we're pointing to that mesoderm. And it develops in a cranial to caudal sequence, and this begins about the 4th week after fertilization. And the first system to form is a pronephric system, the pronephros. And this really is a rather vestigial bit of tissue that occurs in the cervical region of the developing embryo. That's a pronephric system, but it's soon replaced by the mesonephros. And this mesonephros begins in the upper thoracic and lumbar regions around between the 4th to the 8 weeks of development, where you have unsegmented intermediate mesoderm forming these elongated masses of tissue in both sides of the developing embryo. At about 6 weeks of development, this mesonephros is a pretty well-defined ovoid structure, which is on each side of the midline. And the gonad, which is outlined in this image in red, is a structure that develops quite medial on both sides to this developing mesonephros. In formation of the kidney, the mesonephros has a role, and its role is really in the formation of the collecting system of the kidney. So throughout development, the excretory tubules form within this mesonephric tissue, and they empty into the mesonephric duct, which lies laterally, as you can see in this schematic. And finally, the definitive kidney comes from the third stage, which is the metanephric tissue. And this is the tissue that ultimately is destined to form the filtration system of the kidney, the glomeruli and the renal tubules, from metanephric blastema, which is a massive undifferentiated mesoderm, that is in the pelvic region of the kidney. So in the 5th week, the ureteric bud grows out of the caudal end of the mesonephric duct, and it penetrates into this mesoblastic mesenchyme, this blastema. The bud will then lengthen, and again, remember, this bud is not metanephric. This is actually mesonephric tissue, and destined to divide and form the collecting system of the kidney. It also induces formation of the mesonephric tissue to form the filtration system. And what happens is that caps of this metanephric tissue as blastema kind of form around the extending tubules of the collecting duct system. And these tubules, the collecting ducts start to divide and divide and divide to form the collecting system. And at the same time, at the distal end, this cap of metanephric tissue starts to develop into tubules. First is just little masses, then these bodies get hollowed out, and further they turn to S-shaped kind of figures, and over time they develop into the proximal and distal convoluted tubules. And these tubules on the proximal end will differentiate into glomeruli, where capillaries grow in. And at the distal end, they will join with the mesonephric tissue, the collecting duct tissue. And when this process is fully formed, you have fully formed nephrons, the functional units of the kidney. So knowing that and looking histologically, it's pretty apparent that the Wilms tumors are almost perfect mimics in some instances of normal developing kidney. And you can see this on the left-hand side. This is a normal developing kidney from an 18-week-old fetus on the left-hand side, not malignant. On the right-hand side is a Wilms tumor. And I don't think anybody can really tell the difference if you see a high-power image of this without knowing the circumstances of what you're looking at. So with that, modeling the development of Wilms tumors, how do we get from normal development to a malignancy, to an embryological malignancy? And this is like a general schematic outline of how that might occur, where one begins with tissue in the intermediate mesoderm, this nephrogenic niche of tissue, which under normal conditions will be destined to form the kidney. But under abnormal conditions can either form non-Wilms tumors, rarely, or go on to form these nephrogenic rests, these little islands of immature tissue within the kidney. These nephrogenic rests, they can go away. They don't always become tumors. They can sit there and just get fibrotic, or they can become hyperplastic. They can grow. The majority of Wilms tumors are believed to arise from these nephrogenic rests. It's still an open question whether or not you can get a Wilms tumor that skips that step and you go directly from this nephrogenic niche, this mesoderm, into formation of a Wilms tumor. That's an open question, but it's believed that the vast majority of Wilms tumors do arise from these nephrogenic rests. And you can see here that there's a lot of different genes that are involved with this progression of steps, and we're going to go into some of them as we go on. But first, a little bit more about nephrogenic rests. This is an image of a perilobar rest, which is perilobar means at the edge of a renal lobe. This, again, looks quite like a Wilms tumor, the difference being that we have to look at it at a low power and its relationship to the remainder of the kidney. So if one is trying to do a biopsy of these lesions, the pathologist often cannot tell you whether it's a nephrogenic rest or whether it's an actual Wilms tumor. And that's an important thing. Sometimes we're asked to do frozen sections on these things. We try to dissuade that from happening. Anyways, nephrogenic rests are found in about a third of patients with Wilms tumors, apart from the kidney, and even in routine autopsies of children who die of causes unrelated to their kidneys, up to 1% will have a nephrogenic rest in their kidneys if one looks carefully enough. but they're found in the vast majority of patients with bilateral Wilms tumors, and that bolsters the idea that these are underlying lesions that are destined to form Wilms tumors. So as I said before, the fate, they become hyperplastic, they can regress, they can turn into Wilms tumors. How does that happen? Well, I think the first hypothesis was Knudsen in 1971 with his tumor suppressor gene, the two-hit model, which he described in retinoblastoma. He thought that this model could also apply to Wilms tumors, to nephroblastoma or Wilms tumors. Looking at the fact that these patients who had familial Wilms tumor, like the patients with familial retinoblastoma, would present at an earlier age than other children. And this model led to identification of regions with loss of heterozygosity in Wilms tumors, and identifying those regions of the chromosome that were lost led to finding the genes that were present at those locations as candidates for Wilms tumor associated genes. So the first one of those genes I want to talk about is WT1. WT1 was identified by looking at patients with Wager syndrome being Wilms tumor, aniridia, genitourinary anomalies, and a range of developmental delays. These patients were found to have mutations of a gene in that 11p13 region, and further studies disclosed that that was the WT1 gene. So the WT1 gene was the first gene to be associated with Wilms tumor. And patients with this syndrome, this Wager syndrome, actually have a greater than 50% risk of developing Wilms tumor down the road. It's only present in about 10% of patients with Wilms tumor, so it's not all patients, but it's a gene that has a role in normal nephrogenesis. And in addition to Wager syndrome, this WT1 gene is also associated with Dennis-Drash syndrome. Dennis-Drash is a rare syndrome where you see very early onset nephrotic syndrome due to mesangial sclerosis. And this is a trichrome stain that shows collagen as being blue, and you can see the glomeruli are being displaced by collagen, becoming fibrotic. So Dennis-Drash is a syndrome associated with a germline mutation of WT1 with an extraordinarily high risk of developing Wilms tumor down the road. So it's always important for us to look at normal kidney as well as look at the tumor when we get these resection specimens. Another area of great interest is in the IGF-2, H19 genes, where they have loss of heterozygosity, loss of imprinting, which is a process that is operative in the Beckwith-Wiedemann syndrome. I think all of you are familiar with Beckwith-Wiedemann syndrome, and in the interest of time, I'm not going to go through all the different signs and symptoms of a child with Beckwith-Wiedemann. Suffice to say that it is an overgrowth syndrome. Patients with this syndrome have a markedly increased risk of Wilms tumor. They often have Wilms tumor at a younger age compared with sporadic Wilms tumors. And in Beckwith-Wiedemann, it's alteration of 11p15.5 as opposed to 11p13, which arises either through loss of heterozygosity from the maternal allele or loss of imprinting with epigenetic changes in the maternal allele. The net outcome of this would be a hypermethylation of the imprinting center, IC1, and elevated IGF-2. And actually, IGF-2 is the most frequent alteration in Wilms tumor, regardless of whether the patient has Beckwith-Wiedemann syndrome or not. Imprinting is a very interesting process, and it's a process that's operative in Beckwith-Wiedemann syndrome. And imprinting basically refers to the fact that there are a few genes in the human genome, maybe several dozen, that are imprinted. And that means that expression of those genes is governed by whether the gene, the allele, is derived from the mom or the dad. And this is kind of goes against the old hypothesis, one gene, one protein. Sometimes these genes are modified epigenetically. The error happens usually in the post-zygotic after conception, which is why the changes may not be true in every organ or every part of the body. These are mosaic conditions. So with Beckwith-Wiedemann syndrome, you may have loss of imprinting in one of the genes where you may have more production of a growth-oriented protein, which is why these children tend to have overgrowth. They tend to be larger, so on and so forth. And that's due to increased levels of the protein IGF-2. Here's a summary of some, not all, of the syndromes associated with Wilms tumor and the genes that are associated with them. A brief talk about management. As I said before, under the COG protocol, primary nephrectomy for unilateral tumors in patients without Wilms tumor predisposition is how these patients are treated. With biopsy, reserved only for patients who, for whatever reason, cannot undergo upfront surgery, or patients who do not have bilateral disease or tumor predisposition. So those patients will undergo neoadjuvant chemotherapy, much like they do in Europe. The goal being that if you have bilateral disease or you have a susceptibility syndrome, you're very much concerned about maintaining as much normal kidney as possible, so that's why you wouldn't do an upfront nephrectomy. Standard treatment is post-op chemotherapy for almost all patients. The exception in the COG, certain very low-risk tumors, which are stage 1, no anaplasia, fairly low weight tumors, non-syndromic, and absence of loss of heterozygosity to 11p15, they can forego adjuvant chemotherapy. But otherwise, all patients get that chemotherapy. Since we're running out of time, I'm not going to run through all of this, but the therapy obviously will be intensified depending on the risk group the patient is in, to the point where very, very intensive chemotherapy must be given to certain patients with high-risk features. Potential new treatment approaches are being looked at. None of these, I think, are in common use yet, but aberrant pathways, such as the Wnt signaling pathway, targeting of the p53 gene in anaplastic Wilms tumors, inhibition of IGF-1, anti-VEGF therapy, inhibition of Aurora A kinase, inhibition of beta-catenin, all been looked at, being looked at. And in kind of a different strategy is the use of patient-derived xenograft models or spheroids or organoids to see an effect of a specific chemotherapeutic agent on a patient's tumor in a personalized manner. So with that, I think we're about out of time. I just want to summarize this. Take home, this is a childhood embryonic tumor. It's a paradigm of the intersection between organogenesis and tumorigenesis. The genes in Wilms tumor that play a critical role in early nephrogenesis. A half century of cooperative studies, such as COG and PSYOP, have made very impressive gains in the outlook for these patients, but much more needs to be done for those patients who have unfavorable histological features, those with limited access to the state-of-the-art care, and those who suffer relapses down the road. So with that, I want to thank everybody for your attention.
So a while ago, we used to talk about nuclear unrest when we were signing out Wilms tumors. What is your feeling about commenting on nuclear unrest and the significance of it?
My general feeling is I don't like to do it so much because it's really not established. I don't think it's established as, I know there's some thought that it may be adversely prognostic, but on the other case, it's confusing. So the more you put into a report that's confusing, the more problems you're going to end up with. It's not going to affect, I don't think it's going to affect the treatment of the patient. But that's just my personal thing. Yeah.
Your talk was so interesting. I'd like for you to teach me about other diseases as well, so thank you. The intersection with embryology is real interesting, and it's the first I've heard of like nephrogenic rests. So what I'm wondering is that a common like pause point in other tissues as well that have, kind of like a lot of turnover? Is if the liver or the gut, like do other tissues while they're developing also have some percentage of cells that hit pause and then maybe do nothing or maybe have bad consequences later on?
That's a great question. I'm trying to think about other tumor systems where you have something similar to that. I don't recall it. Like, I'm thinking of other embryological, hepatoblastomas, neuroblastomas. I don't know if there's anything that really is similar to that occurs in the kid. Yeah. I mean, I don't know, Raj, you probably have
I
some.
mean, I don't know about a pause, so to speak, but as you alluded to, neuroblastoma, and many, I think, pediatric, especially early onset tumors seem to mimic stages of normal embryogenesis.
Yeah.
Well, Bruce, really want to thank you. That was such a marvelous talk and such
Thanks,
a great overview from the past to really the most contemporary status of things. So thank you very much.
Thank you.